Hello and Assalamualaikum. Good day everyone. I hope that you are in the pink of health. Today, we will discuss on the image evaluation of posteroanterior chest X-ray. Let's get started. This is the lecture outline for today. We will start with radiographic anatomy, followed by identification of projection. Next, we will further discuss on the criteria of correct positioning and exposure factors. Lastly, we will learn how to evaluate PA chest radiograph by using PACEMAN method. Firstly, let's take a look at the radiographic anatomy of PA chest X-ray. As a radiographer, we need to have a good knowledge on anatomy so that it will make it easier for us to identify them on the radiograph. This label image shows among the structures that can be identified on PA chest X-ray. We can see here the air-filled trachea, the right lung apex, right scapula, right lung, right breast shadow, right hemidiaphragm, right costophrenic angle, left clavicle, left sternoclavicular joint, left fourth posterior ribs, aortic arch, carina, left fourth anterior rib, heart shadow, left cardiophrenic angle, and gastric bubble. It is very important for us to precisely identify the structures. Next, let's continue with the identification of projection. Before we start evaluating the images, we need to first and foremost identify the projection of the image. This is important because the other criteria of image evaluation, such as positioning or collimation, will be depending on the said projection. This image shows a radiograph of PA projection of the chest. This is chest because the thoracic vertebrae is at the midline of the radiograph with the 7 thoracic vertebra at the center of the radiograph. In addition, the entire lung field showing the abscess, lateral lungs and costophrenic angles are included in the radiograph. This is a PA radiograph because both lung fields are demonstrated bilaterally to each other. Furthermore, it is very important to differentiate between PA and AP projection of the chest. In order to differentiate between these two, we should evaluate C6, C7 and T1 vertebrae. In PA chest X-ray, the vertebral bodies of C6, C7 and T1 will appear distorted. The intervertebral disc spaces will appear closed and spinous process and laminae are well visualized. In addition, in PA chest X-ray, the spinous process of C6, C7 and T1 will be seen at the superior aspect of its vertebral bodies. Next, we will move on to the third part, which is the criteria of correct positioning. The first positioning criteria that we can assess is rotation. In PA chest, the patient should not be rotated. It can be evidenced by looking at two things. The first one is by measuring the distance from the medial end of clavicle to the vertebral column, and the second one is to measure the length of the posterior ribs. Firstly, to evaluate rotation, we can measure the distance from the medial end of clavicle to lateral vertebral column. The distance from the medial end of clavicle to lateral vertebral column should be similar on both sides to indicate no rotation. This can be achieved when the mid-sagittal plane is perpendicular to the IR, whereby the patient's weight should be distributed equally on both feet and shoulders and arms are at equal distance to IR. In PA chest, smaller distance will indicate the side of patient's position closer to the IR. For example, if the distance from the medial end of clavicle to lateral vertebral column is smaller at left side, it indicates that the patient was rotated to the left. Hence, how to improve if this happened? We need to rotate the patient's body to the right until the MSP is perpendicular to the IR. Secondly, the length of the posterior ribs can be used to evaluate rotation. The length of these posterior ribs should be similar bilaterally to indicate no rotation. This can be achieved when the mid-sagittal plane is perpendicular to the IR, whereby the patient's weight should be distributed equally on both feet and shoulders and arms are at equal distance to IR. In PA of the chest, shorter length of the posterior ribs indicating side of the patient's position closer to the IR. For example, if the left posterior ribs are shorter than the right, the patient was rotated to the left. Hence, how to improve if this happened? We need to rotate the patient's body to the right until the MSP is perpendicular to the IR. Next, the second criteria for correct PA positioning is to seek evidence of tiltation. During positioning, the tilt of the superior mid-coronal plane can be determined by assessing the amount of apical lung field shown above the clavicle, the relationship between the manubrium to the thoracic vertebrae, and the degree of lung and heart foreshortening. If the MCP is parallel to the IR, approximately 2.5 cm of the apical lung field will be seen above the clavicle. The manubrium will appear superimposed with T4 vertebra, and the lung and heart will be shown without foreshortening. There are two scenarios that tilting might occur. If less than 2.5 cm of the apical lung field seen above the clavicle, or the manubrium is projected at T3 or higher, and the lung and heart appear foreshortened, it indicates that the patient was tilted posteriorly or backward. The second scenario is if we measure the area of the apical lung field above the clavicle and it is more than 2.5 cm, or the manubrium projected at T5 or lower, and the lung and heart appear foreshortened, it indicates that the patient was tilted anteriorly or forward. This error is commonly occurs among patients with protruding abdomen or pendulous breast. In order to improve the positioning of the patient, we need to make sure that the superior mid-coronal plane are parallel to the IR. Next, the third criteria for correct PA positioning is orientation of the clavicles. During PA chest, the lateral end of the clavicle should be positioned on the same horizontal plane with the sternal end of the clavicle. This can be accomplished by depressing the patient's shoulders, whereby it can help in providing better visualization of apical lung field. Non-depressions of shoulder will cause elevations of lateral ends of the clavicle. Next, the fourth criteria for correct PA positioning is the visualization of scapula within the lung field and the humerus abduction. In PA chest, the scapula should be projected out of the lung field and the humeri should be abducted away from the chest area. The scapula can be projected out of the lung field by asking the patient to rotate the elbows and shoulders anteriorly. The humeri can also be abducted by placing the patient's hands on the hips. Common error that might occur is the superimposition of the scapula with the superolateral lung field. If it occurs, the scapular densities might hinder the detection of abnormality at the lung's periphery. Next, the fifth criteria for correct PA chest is lung aeration. We can assess the lung aeration by evaluating the posterior ribs shown above the diaphragm. In PA chest, at least 10 or 11 posterior ribs should be shown above the diaphragm. It is because the PA chest was performed in upright position, whereby the abdominal organ and diaphragm will shift inferiorly, hence allowing more space for maximum vertical lung aeration. If less than 10 posterior ribs are demonstrated above the diaphragm, it indicates inadequate inspiration, hence causing the lungs not fully inflated. As such, it is very important for us to practice with the patient and ensure that the exposure taken after second full inspiration. Next, we will discuss on the fourth part, which is evidence of adequate exposure factors. For each images, beam penetration, contrast and density should be sufficient in order to visualize structures of interest. For contrast and penetration for PA of the chest, the thin structure, which is the vascular lung markings, and the thick structure, which is BCO or the bony cortical outline of ribs and vertebral bodies behind the heart, should be visualized. This will indicate that the KVP is sufficient for penetration and contrast. It is worth to note that although lower KVP can sufficiently penetrate the lung field, it seldom gives enough penetration to show structures within and behind the heart shadow. Next, for density and detail, the thin structure, which is air-filled trachea, should be seen until the carina, and the thick structure, the bony trabeculate pattern of the upper thoracic vertebrae, should also be visualized. Next, we have reached the fifth part, which is evaluation of PA of the chest using PACEMAN method. Before we start, I would like to highlight that it is important for us to have a systematic approach in radiographic image evaluation so that it can help us to consider all aspects before we decide to accept or reject the images. This is the outline of PACEMAN method, whereby it comprises of P, projection and positioning, A for alignment, C for collimation, E exposure factor, M for marker, A aesthetic, N for name, and last is conclusions or acceptability. First and foremost, let's start with the first P, which is projection. This image shows a radiograph of PA projection of the chest. This is chest because the thoracic vertebrae is at the midline of the radiograph. Besides, the entire lung field showing the epicers, the lateral lungs, and costophrenik angles are included in this radiograph. This is a PA because we can see that both lungs are seen bilaterally to each other. In addition, in order to differentiate between PA and AP of the chest, we can evaluate at the C6, C7 and T1 vertebrae. In this radiograph, the vertebral bodies of C6, C7 and T1 appear distorted, the intervertebral disc spaces are closed, and the spinous process and laminae are well visualized. Besides, we can see that in this radiograph, the spinous process of C7 and T1 are seen at the superior aspect of its vertebral bodies. The second P, we should evaluate accuracy of positioning. Let's start with the first positioning criteria, which is rotation. This image shows a smaller distance from the right medial end of clavicle to vertebral column as compared to the left side. In addition, the right posterior ribs appear shorter than the left. Hence, this indicates that the patient was rotated slightly to the right. How to improve this? We need to rotate the patient's body to the left until the MSP is perpendicular to the IR. This can be achieved when the patient's weight is distributed equally on both feet and shoulders and arms are at equal distance to the IR. Next, the second criteria is to seek evidence of tiltation. This image of PA chest shows decrease in apical lung field seen above the clavicle. However, the manubrium is demonstrated superimposing with the T4 vertebra. The lung and the heart are also shown without foreshortening. Hence, this indicates that there is no tilting of patient's superior mid-coronal plane. Next, as discussed previously, we can see that less than 2.5 cm of apical lung field seen above the clavicles. However, it is not due to tiltation, but it is due to the poor shoulder positioning, which resulted in elevations of the lateral end of clavicle. Here we can see that both right and left lateral end of clavicle are elevated. It is not at the same horizontal plane with the medial end of the clavicle. Therefore, in order to improve the patient's positioning, we need to ask the patient to depress their shoulders. Next, this radiograph shows that the scapula are projected out of the lung field and the humeri are abducted away from the chest area. For lung aeration, this image shows 10 posterior ribs demonstrated above the diaphragm, indicating full lung aeration. Let's move to the second part of PACEMAN, which is A for alignment. For alignment, there are 5 things to be assessed, which are the alignment between the X-ray tube and patient, the alignment between the X-ray tube and image receptor, the alignment between patient and image receptor, and the centering point for this radiograph and this projection. The alignment between X-ray tube and patient for this radiograph cannot be determined because there is no presence of borders of collimations. For this radiograph, the alignment between X-ray tube and image receptor cannot be determined because there is no evidence of collimation borders. Next, the alignment between patient and image receptor is incorrect because the distance from the edges of film to the central structure is unequal. Next, the centering point for this radiograph cannot be determined because there is no evidence of collimation borders, whereas the standard centering point for this projection is at the MSP at the level of T7. Next, let's move to C, collimation. Collimation should be done to all four borders of the film, and it should include at the superior part C6, C7 and the lung abscess. At the lateral side, it should include the lateral lungs or the thoracic cage, and at the inferior part, it should include the costophrenik angles. There is no evidence of radiation protection apparatus seen on this radiograph. Now, we will continue with evaluation of E, which is exposure factor. For contrast and penetration of PA chest, the thin structure, which is the vascular lung markings, can be seen, whereas the thick structure, which is the BCO of ribs and the vertebral bodies behind the heart, cannot be seen. This indicates that the KVP is insufficient for penetration and contrast. For density and detail, the thin structure, which is the air-filled trachea, can be seen until the carina, whereas the thick structure, which is the bony trabecular pattern of the upper thoracic vertebrae, cannot be seen. This indicates that MAS is also insufficient for detail and density. Therefore, in order to improve this radiograph, we need to increase the KVP by 15% while maintaining the MAS in order to allow adequate penetration and density. Let's move to the fifth criteria, which is M for marker. There is evidence of an anatomical marker shown in this radiograph, and it is correctly placed on the left side of the patient's body. However, it is placed inappropriately because the upper half of the left marker was not within the collimated area. The marker placement is not superimposing any structure of interest. Next, let's continue with the second A under PACEMAN, which is aesthetic. The film size used is 35 × 35 cm, which is sufficient to demonstrate all structures of interest. There is no evidence of artifacts seen on this radiograph. However, we can see that the breast shadows are interfering with the structures of interest. In order to improve this, we can ask the patient to shift the breast laterally. Next is the last part under PACEMAN, which is N for name. There is no patient's name and ID, date and place of examination seen on this radiograph. They should be clearly visualized on the radiograph at the appropriate area and not superimposed with any structures of interest. Great! We have successfully evaluated the image using PACEMAN method. However, let's not stop there. We need to decide the acceptability of this image before proceeding with the next radiographic procedure. Based on the evaluation, this image should be rejected due to insufficient exposure factor and absence of patient's name and information. Corrective measures should be applied when repeating this examination to ensure passability of the image. That's the end of today's session. I hope that this session can assist you in the evaluation of PA chest X-ray. Before we end, I would like to share with you a quote from Carlton and Adler. Radiographers can make mistakes, but true professional radiographers are able to correct their mistakes by using a careful and critical analytical process to determine exactly what went wrong. With that, thank you and stay safe, everyone.